This is the seventh in a series of presentations on radiography of joint disorders in veterinary patients. The intent of this presentation is to describe and provide examples of hip dysplasia, and by the end of the presentation, you should be able to describe and review images for appropriate diagnostic quality in the evaluation of the hips, as well as describe and identify the radiographic changes in and diagnose hip dysplasia. As a brief overview, hip dysplasia is an inherited disorder of abnormal development of the coxfemoral joint, leading to formation of secondary degenerative joint disease. And in fact, hip dysplasia is the most common cause of hip arthritis. Hip dysplasia is a developmental age-related disorder, and in fact, the phenotypic manifestations are not present at birth. A variable time must elapse before the radiographic changes are evident, and clinical signs typically develop around 5 to 12 months of age. And after that, the radiographic changes will progress with age. Hip dysplasia principally occurs in large breed dogs, but it's important to note that all breeds can be affected, including small breed dogs, and cats are also affected. Finally, hip dysplasia is typically a bilateral disease, but it can be identified as asymmetric and even unilateral. When we go to position the patient for evaluation for hip dysplasia, the extended limb ventrodorsal view is the most beneficial to evaluate the hips. And in fact, it is the view that is used by the Orthopedic Foundation for Animals during the hip dysplasia certification. To obtain this view, we will have the patient lying on their back, and then the pelvic limbs should be extended as far as possible to be parallel to each other and parallel to the table, as well as making sure that they are straight by having the patella on midline in the center of the femur. In order to do this positioning, typically your patient has to be fairly well sedated. When we look at the extended limb ventrodorsal view that is nicely done on the right side of this image, we can see that the right and left femurs are parallel to each other. They don't look distorted because they are parallel to the table, and then each patella is nicely centered on midline. When we assess the pelvis to make sure that there's no rotation of the pelvis, we can look at the wings of the ilia, and they should be symmetric from one side to the other. We can also look at the obturator foramen, which should also be symmetric from right to left. And then finally, we want to see that the femurs cross the ischial tuberosity symmetrically. So this is a nicely positioned view, and this happens to be a dog with normal coxfemoral joint anatomy. There are other methods of hip screening programs that are described in the reference at the end of the presentation. It's important to recognize the normal hip anatomy so that you will be able to recognize when there is an abnormality. And so this slide is describing what the normal radiographic appearance is. And this is a magnified and tightly collimated image of the left coxfemoral joint. So the pelvis has the acetabulum that is formed from the ilium, the pubis, and the ischium, and that acetabular cup should be nice and deep C-shaped. That acetabular cup has a dorsal rim, and the dotted black line here is showing you where that dorsal rim is, so we can see that this is a nice C-shaped cup. That is the kind of receptacle for the femoral head, and so that femoral head should fit nicely within that cup. And when I look at the femoral head, I'll usually try to identify where the thin physeal scar is, where that physis would have been, and we want to assess how much of that femoral head is covered by that dorsal acetabular rim. And as in this patient, it should be greater than 2/3 coverage. Then we want to assess the actual joint space, but it's important to recognize that there's parts of the joint space that are not appearing to be congruent. And that is when we get to this medial aspect, because there is an acetabular kind of notch right here, so it looks like there's widening of the joint space. And then two, that femoral head normally has a small flattened area, which is our fovea capitis. So when we look at the joint space congruency, we're really just looking at this kind of cranial part right here, but we want to see that it's nice and congruent in between where these purple hash marks are. And then the femoral head should be seated on kind of a thin femoral neck that narrows down before you get into the greater trochanter here. And so this is a very normal appearing patient. And then this is that same patient without the marks on it, so that you can actually see this dorsal acetabular rim. You can see that physeal scar. You can see how that femoral head is nicely covered. This slide lists all the different findings that we might identify in a patient with hip dysplasia. And again, depending upon where you are in the kind of process, you may see a few of the changes and you may see many more of the changes. So certainly, because hip dysplasia is an abnormal development of the actual kind of coxfemoral joint, then one of the things that we will identify is that that acetabulum is no longer nice and deep and C-shaped. And so in this patient with dysplasia, this acetabulum is more shallow. You can compare it back to the normal. And in fact, it has kind of more of a flaring of the cranial margin. So it doesn't have a nice kind of margin that comes out perpendicular to the long axis of the ilium. And then as part of that shallow kind of acetabulum, oftentimes the femoral head is then not going to be covered appropriately. And in fact, this one has very little coverage. And so in fact, this joint is subluxated. So we can look for incongruency of that joint space. We can have subluxation or even complete luxation. And then the femoral head will start to remodel and may have additional flattening or be abnormally shaped compared to normal. Remember that there is always that kind of flattened area of the fovea capitis, so we don't want to think that that is abnormal flattening. And then we'll start to form secondary degenerative joint disease, which will be osteophytes in various sites. This patient has some thickening of the femoral neck from some osteophytes. Otherwise, I don't see any osteophytes. And then if it gets very severe, you can actually have subchondral sclerosis and then even some kind of cyst-like formation. So here's that same patient, and these are just some schematics to help you see some of the things that we're identifying. Here's an example of a patient that has mild bilateral hip dysplasia. This image in the middle here is the extended limb ventrodorsal view showing both of the coxfemoral joints. And then again, typically we want to get all the way down to the stifles to know we have good positioning. And then over here on the right of the slide is just a close-up view of the left coxfemoral joint. And what I can see bilaterally, but I'll describe on this close-up view, is that this acetabulum is mildly shallow. It's not as deep and C-shaped as the normal patient. Because of that, this femoral head, and here's our physeal scar, this femoral head is only covered by about 1/2 of the dorsal rim of that acetabulum. So that is leading to some incongruency or almost subluxation of the coxfemoral joint. So that is shallow acetabulum with poor femoral head coverage. And then this patient has some sites of osteophytes. There are osteophytes here on the cranial rim of the acetabulum. These are actually probably enthesophytes at the attachment of the joint capsule when it gets pulled during the laxity that's going on. And then adjacent to this physeal scar, there's another line of sclerosis, which are osteophytes along kind of the joint capsule margin. And then very early, sometimes in arthritis, you'll also get this line of sclerosis along the femoral neck, which is the caudalateral curvilinear osteophyte line, which is also known as a Morgan line. So this patient has mild bilateral hip dysplasia, so abnormally shaped coxfemoral joints, and then has mild secondary degenerative joint disease. This is a patient that has moderate bilateral hip dysplasia. Again, I have the extended limb ventrodorsal view and then a magnified close-up view of the left coxfemoral joint. Compared to the previous patient, the acetabula are even more shallow in this patient, so shallow and flared, leading to very poor coverage of the femoral head, so probably about 1/3 of the femoral head here. Physeal scar is covered by the dorsal rim of the acetabulum, so that is leading to joint subluxation or incongruency. And this patient has very early osteophytes, both along the femoral neck right here and also on the medial side of the femoral head. Acetabulum itself doesn't have osteophytes. And then again, this is a bilateral finding, a little bit worse with the mild osteoarthritis on the left side compared to the right side. And then this is a patient with very severe bilateral hip dysplasia. This is a younger patient that is affected earlier. And on the extended limb ventrodorsal view, we can see that both sides are fairly equally affected. We can also tell that clinically the patient is lame bilaterally because this patient has very little muscle mass on either side. And although that can be challenging to decide when both sides are atrophied, I think that this is a real finding in this patient. So these acetabula are very, very shallow compared to the prior two patients, very flared, no longer that kind of deep C shape. There is very little, like maybe a quarter of femoral head coverage, so dorsal rim of the acetabulum covering only about a quarter of the femoral head. So here's the femoral physis that isn't quite closed yet. So a bilateral abnormality. This patient does not yet have any secondary osteoarthritis. So in an ideal world, we'd maybe be able to try some surgical intervention like a triple pelvic osteotomy prior to development of degenerative joint disease with the intent to try to slow or potentially halt the process. Here's a patient that I gave you the lateral view as well as the extended limb ventrodorsal view, and this patient has severe bilateral hip dysplasia but also has moderate secondary degenerative joint disease. So this patient is older, all of the physes are closed, shallow acetabula bilaterally. The dorsal rim is providing less than 50% coverage of the femoral head on the left and probably only a third coverage of the femoral head on the right. Notice that this patient has very thickened femoral necks, which is due to the osteophytes, also some sclerosis here, so osteophytes of the femoral necks bilaterally, some osteophytes on the medial aspect of the femoral heads, and then some mild osteophytes up here on the cranial aspects of the acetabula. So again, this patient has moderate secondary degenerative joint disease. What I want to note is that on the lateral view, it's very challenging to evaluate any of those abnormalities because both of our coxfemoral joints are superimposed over the acetabula as well as over each other. So unless the arthritis gets very, very severe or unless there's subluxation or luxation of that hip, it's going to be challenging to identify an abnormality. However, I do believe that obtaining the lateral view is always part of a complete diagnostic study because the patient, yes, has hip dysplasia and arthritis, but there could be another abnormality that could explain the clinical signs. So maybe something in the spine, something somewhere else in the pelvis or the pelvic limbs, or even sometimes in the retroperitoneal space or the abdomen. So again, an orthogonal study or orthogonal view is always part of a complete study. Here's another example of a dog with very severe bilateral hip dysplasia and very severe secondary hip osteoarthritis. And if you look at this patient on this extended limb ventrodorsal view, there really is no acetabulum to speak of. And in fact, I see like really no dorsal acetabular rim covering either femoral head. And then there are severe osteophytes and subchondral sclerosis along the acetabula, as well as along these femoral necks, which are markedly thickened and sclerotic, and the femoral heads are abnormally shaped and flattened from this severe secondary degenerative joint disease. On this dog's lateral view, if we look really closely, we can notice that this femoral head is not within the acetabulum, so it is actually mildly luxated, and I don't know what lateral view this is, so it's hard to tell if this is left or right. Finally, we need to remember that all breeds of dogs, so including small breeds, can be affected as well as cats. And so on this slide, I've given you a couple examples of feline hip dysplasia. On the left of the slide is the normal pelvis of a normal cat that is still fairly young because we have open physes. And I want you to just think about the coxifemoral joint conformation compared to the dog. Notice that in the cat, the acetabula just don't seem quite as deep or cup-shaped as the dog, and maybe don't have quite as much coverage of the femoral heads, but the femoral the coxifemoral joints are still congruent. Notice that the pelvis also is a little bit more narrow and elongated compared to the dog. So here's our normal patient. We have two examples of hip dysplasia. In the middle of the slide is a patient that probably has mild dysplasia with mild to moderate secondary osteoarthritis. Notice that in the cat, the femoral heads and necks are relatively spared when we have secondary osteoarthritis, and they like to actually form a lot of new bone at the kind of cranial and dorsal aspect of the acetabulum as part of their osteoarthritis. This patient on the right actually has more severe and advanced degenerative joint disease from the hip dysplasia, and so not only do we have all of that new bone, so that kind of endesopathy and osteophyte proliferation on the acetabulum, both cranially as well as caudally, but this cat has misshapen femoral heads with femoral head osteophytes and then femoral neck thickening. The incidence of hip dysplasia in domestic short-haired cats is probably about 7%. It is higher in some purebreds, with the Maine Coon cat actually being affected up to 20%. The extended limb ventrodorsal view of the pelvis is that view that is submitted to the Orthopedic Foundation for Animals for certification of the hips. And again, as with the elbows, the patient must be at least 2 years of age in order to be certified. When the hips are sent in for certification, there is actually a more thorough classification compared to the elbow classification. Hips that are non-dysplastic are actually rated as being excellent, good, or fair. And if you look on the OFA website, it will give you examples of what that confirmation will look like. There is a classification of borderline, which is when they're not truly dysplastic, but aren't really very non-dysplastic, and those patients can be submitted again. And then when the hip or hips are dysplastic, they are graded as mildly, moderately, or severely dysplastic. For OFA evaluation, the process is that the radiographs for both pelvic and elbow certification are sent to 3 board-certified radiologists who each independently score the hips and elbows, and then those scores are averaged to give you a final score. So, for example, if you had 3 radiologists, one said the hips were excellent, one said the hips were good, and one said the hips were fair, the patient would get a score of good. And if you had 2 radiologists that rated the hips as excellent and one that rated the hips as good, then the patient would be given an excellent score. The textbook chapter and pages give more information on hip dysplasia, and you can also read more about hip dysplasia as well as elbow dysplasia on the OFA website.